Great. We'd like to welcome everybody back. We hope you're able to stretch your legs. And now since it's 2:20 Eastern time, and we're ready to begin the second half of the day. So with our session 2, it is my privilege and honor to introduce to you our esteemed facilitator, Dr. Robert Kane, President and Chief Executive Officer of our American Association of Colleges of Osteopathic Medicine. He will share with you the session objectives. Dr. Kane, take it away.
Thank you, Dr. Cease, and good afternoon, everyone. Welcome to Session 2, National Action to Improve Workforce Wellbeing. As noted, we will spend the next 30 minutes hearing about ways we might leverage national organization platforms to build positive change to improve workforce well-being, retention, and the pipeline of healthcare workers in the context of COVID-19 and afterward. There are 6 organizations to speak during this session. We've asked each participant to limit their remarks to no more than 4 minutes. There is no Q&A, but we hope this session can be dynamic through the use of the chat function. The 6 participants have been encouraged to respond to audience chat comments with resource links and to answer questions. In addition, we have also invited clinical well-being network organizations to be ready with resource links and to share their own progress in workforce well-being and retention. So let's get started. First, we'd like to hear from Noelle Smith, Senior Director of PA and Industry Policy and Analysis from the American Academy of Physician Assistants. Noelle?
Thank you very much. Good afternoon, everyone. The American Academy of PAs is concerned with the growing incidence of burnout among clinicians in the U.S. Burnout impacts not just clinicians, however, but also their colleagues, their families, and their friends. The strain on the U.S. healthcare system will continue to grow as the population ages, access to healthcare and insurance increases, and EHRs continue to place an administrative burden on clinicians. That cumulative effect of the mismatch between the ambitions of PAs and the increasing demands of the work environment can lead to disengagement at work, lack of satisfaction with one's career, and ultimately burnout. In turn, clinician burnout can lead to leaving the healthcare workforce, which decreases patients' access to care. It may increase the overall cost of care, and it can impact patient outcomes and patient safety. To address this crisis, in 2019, the American Academy of PAs created a task force on burnout to raise awareness of burnout, evaluate the existing research, to identify resources for clinicians, and finally, to convene a stakeholder meeting for organizations to help develop strategies to manage and prevent burnout in the PA profession as they work with other healthcare providers. PAs are dedicated to expanding access to care and transforming health and wellness through patient-centered, team-based medical practice. We believe it is paramount that interventions and supports are in place for all clinicians, and that the best patient outcomes will come from teams that are healthy and high functioning. We believe that a fundamental change within many organizations will be needed if we are to focus on the system-wide factors, as opposed to just those interventions that focus on the individual. System-wide action should be focused on the goals of creating a positive work environment with opportunities for growth, for reducing administrative burdens, for enabling technology solutions, and for supporting all clinicians regardless of their position. Studies have shown that burnout is linked to lower clinician productivity, greater utilization, and higher turnover, which are consequences associated with reduced access to care and significantly increased healthcare costs. In addition, there is a potential for burnout to reduce the quality of patient care, and research has indicated that burnout adversely impacts teamwork, which in turn may have a detrimental impact on patient safety. Our own research has shown that burnout, and specifically emotional exhaustion, plays a significant role in job satisfaction. And that work reflects research that has been found in other professions as well. And there are factors that can mitigate this. For example, we're finishing up a study right now in collaboration with clinicians at New York Presbyterian to indicate that PAs that feel appreciated in their role, that are given more opportunities for growth, they have an opportunity to have pride in their work, they have work-life balance, and are given some autonomy in their work. those things will mitigate the effects of emotional exhaustion and decreased satisfaction with their employer. But none of this should be surprising. However, best practice should not be taken for granted when thinking about systemic changes that are needed. We need to understand the underpinnings of any professional satisfaction that may mitigate clinician turnover, which in turn may lead to cost savings for the organization. So showing that value proposition. It may help lead to better resiliency and mental health for clinicians and potentially better patient outcomes. Through ongoing endeavors across the organization, AAPA will continue its program of conducting research on the issue of burnout, as well as educating PAs on the importance of clinician well-being and resilience. We welcome collaboration on this issue with other professions and healthcare systems. We are continuing our outreach to a broader healthcare community and have made our resources available at no cost to anyone. And we encourage you to visit us online at the website provided, or for you to reach out to me directly. And finally, on May 23rd, 2022, we're convening a diverse array of thought leaders at the Symposium on Clinician and Clinical Student Wellbeing in a team-based setting. The purpose of that is to discuss what is truly needed to make systems change tomorrow. In conclusion, PA's contributions to the healthcare team, when allowed to work at the top of their education and training and given opportunities to grow, will support work-related well-being among all healthcare providers, which will in turn increase workforce retention. Thank you.
Thank you, Noelle, for that input from the AAPA. Next, we'll hear from Connie Barden, Chief Clinical Officer, the American Association of Critical Care Nurses.
Thank you, Dr. Kane. Hi, everyone. It's great to be here and my pleasure to take just a couple of minutes to familiarize you with a key resource that we have here at AACN. Beth Watson outlined earlier who we are. The American Association of Critical Care Nurses is the largest specialty nursing organization tending to the needs of the nation's acute and critical care nurses. We think there are about 500,000 of those, 130,000 of whom are our members. We're very proud of that. I'm going to talk a little bit about the Blue Book that you see there on your screen. That's what it's lovingly called here at AACN. And the impetus to create this resource did not start with the pandemic. In fact, it started 15 or 20 years ago for us. AACN, which is a nonprofit, of course, educational organization, began to hear from our members back then, in the middle of the 2000s, that while they loved our educational resources and so forth, they said, someone's got to start speaking up on behalf of nurses. And we look seriously at our role as an advocacy, in advocacy, and how we could sort of flex our voice and speak up more on behalf of nurses. It's quite an ask, and we needed to determine what kinds of things we should tackle in that regard. Without a doubt, and across the board, 15 to 20 years ago, nurses said to us, someone has got to speak up about these environments in which we attempt to deliver care. Out of that was birthed the Blue Book, which first was released in 2005. This is a picture of the second edition, which came out in 2016. The third edition is now being formulated and we will be out before too long. This is an intentionally concise resource that defines 6 foundational standards that we believe are essential for healthy work environments. Things like true collaboration, effective decision-making, appropriate staffing, authentic leadership, and so on. And they're simplistically stated and then supported with what we call critical elements that describe how to bring these into being. This has been the underpinning of our work, and there are 3 ways in which we as a national organization have made progress in bringing this forward. First of all, it's a golden thread in all of the education that we do, whether it is our blogs, our conferences, our summits, publications, etc. It's embedded in the work that we do. Secondly, we've created a valid and reliable work environment assessment tool that's free. You can find it there at the link that you see on your screen. Clinicians can go in there on a unit level and assess very quickly the health of their work environment, gives them a baseline and then a place from which to periodically check the health of the work environment and know where to spend their efforts on improving that environment. And the third thing is we have a pretty solid program of research around this. We've now conducted 5 national level surveys with critical care nurses looking at the health of work environments across the country. The last one was conducted just at the end of last year, and we will release those data in the next month or two. So that we think keeps us in touch with the pulse of what's going on related to the work environment. The other thing you see on the screen is what I would call a relevant outcropping from this work. When we've established the foundational elements for a healthy work environment, then we can partner with others to drive needed action. And this think tank, a national level think tank focusing on appropriate staffing, is now in the works. We are leading this with 4 other major nursing organizations to look at this crisis that has been referred to so much today. So if you'd like to learn more about that work, you can click that link. This think tank will segue into being a task force. And with our other colleagues, we really intend to address this crisis level issue of staffing in nursing. So in summary, I would say probably it takes 4 things for national organizations to do this kind of work. First of all, a vision. Second of all, partners. No one can do this alone. Thirdly, boldness. You have to kind of go out there sometimes where you've never gone before. And finally, tenacity and persistence, because these are generally longstanding issues that have taken a long time to get embedded in our work and won't be fixed overnight. But we're committed to doing so. So thank you for the time, Dr. Kane.
Thank you, Connie, for sharing that input from the critical care nursing community. And next, we'll go to Kim Templeton, past president, the American Medical Women's Association. Kim?
Thank you very much for the opportunity to speak today on behalf of the American Medical Women's Association. Multiple studies have indicated that burnout prevalence is higher among women than among men physicians. The strategies recommended in the National Academy of Medicine discussion paper on gender-based differences in burnout in 2019 still hold true, especially the need to emphasize institutional factors that can impact women physician well-being, including addressing harassment and biases such as gendered pay and leadership gaps, as well as the additional issues faced by women physicians of color. Raising awareness of these issues is something that we have been and are continuing to work on through AMWA. But as has been discussed today, the pandemic has highlighted or exacerbated pre-existing issues in healthcare, and there are some that preferentially impact women. Women physicians historically have provided the majority of child and elder care and the responsibility for household tasks. This was heightened during the pandemic as schools closed or typical elder care was no longer available. As noted by Frank et al. In a publication last year, women physicians reported more work-home and homework conflict during the pandemic than did men. We know from studies prior to the pandemic that these types of conflicts can negatively impact well-being. Until societal gendered expectations of women change, this means that there needs to be recognition and support of women's roles outside of the workplace, even as the pandemic recedes. There should be flexibility in work scheduling and family leave that is career long. As women transition from caring for children to caring for aging parents or significant others, based on the study that we did here of senior women physicians, caretaking roles can extend up to and past retirement. Increased responsibilities at work and at home during the pandemic has also impacted the career trajectory for women physicians, especially those in academia. Women in academia need additional support for mentorship and sponsorship, in addition to getting their research careers back on track. Sponsorship in particular was an issue for women prior to the pandemic and needs additional focus. There is a risk that women physicians, especially those in academia, including those more senior, may have become even more invisible as they faced additional responsibilities at home. The need for a focus on mental health resources was mentioned in the 2019 discussion paper, including the need to tailor these to the schedules of physicians. During the pandemic, AMWA has collaborated with efforts to provide immediate support virtually. However, moving forward, more long-term mental health resources are needed that are available when physicians are available, as others have mentioned today, but remembering that this can be harder for women considering their other responsibilities. However, having these resources available is not sufficient, as we also need to address the stigma related to seeking mental health help. We're working on that at AMWA through our Humans Before Heroes initiative that is assessing language on state licensure forms for questions related to prior mental or physical health issues, and providing support for those who would like to change the language in their state, similar to the language suggested by the Federation of State Medical Boards. We're now transitioning to starting similar work on addressing language on hospital credentialing forms. As a result of this, more women than men during the pandemic have either left medicine or no longer working full-time, further worsening the physician shortage. AMWA is working to address that by focusing on the second topic of physician reentry. Physician reentry is a return to clinical practice following an extended period of clinical inactivity. This extended period of clinical activity is defined at the state level, but nationally averages about 2 years. This impacts both women and men, but women tend to leave practice earlier, usually because they leave to care for family members, meaning that they tend to return to practice earlier, giving them a longer period of time potentially in practice. So AMWA is addressing reentry as we look for ways to facilitate the return to practice, such as raising awareness of the implications of leaving practice and reentering among trainees and young physicians, trying to make the process more visible, and addressing barriers such as funding that are issues faced by those attempting to reenter practice. Facilitating reentry could help to address the physician shortage more quickly than, but in concert with training more physicians. The pandemic has highlighted issues in healthcare impacting women physicians. Now that the impact of these may be more visible, it's time to start the conversation, including listening to the concerns of women physicians so that they know that they're heard and valued, so that we can all work together to support women in medicine. Thank you.
Thank you, Kim, for sharing these key action areas from AMWA. And now we'll hear from Georgia C. Benjamin, Executive Director, American Public Health Association.
Hi, everyone. Listen, thank you very much for being here for this very important conversation. You heard Dr. Deb Harry talk a little earlier, and I'm just going to build on some of the things she said. You know, I'm going to speak very specifically about the governmental public health workforce. Like everybody else in the health field, long hours, high stress, certainly fear of a disease. Very much public health was very much like our clinical care colleagues who were out and about and were unable to work from home on remote tools. I think one of the big issues is throughout this pandemic, the public health community has really suffered in many ways some lack of support. Political leaders who have, quite frankly, turned their backs on some of their public health officials, the public, which has, as someone mentioned earlier, initially was for us before they were against us. And I think a lot of disinformation, which has ultimately resulted in the lack and loss of public health authorities. We actually have legislators right now, in essence, removing what would be in effect our clinical practice authorities from the public health officials by removing their public health legal authorities. So we're really focused at the American Public Health Association in really two big areas. Number one, obviously, like everyone else, working very, very hard to make sure that we once and for all build the public health system that every community deserves to have, making sure that the resources are there, adequate resources, that the workforce is well supported. You heard earlier a lot of discussion around the loss of workers from the public health field, and that's going to accelerate greatly over the next couple of years. But I think one of the biggest issues we're going to have to work on, and my association has certainly begun working with others, is trying to change the fundamental operating environment in which public health works. And that means doing a better job of working with local elected officials, political leaders, resource allocators, to explain what public health is, who does it, how the work gets done, the importance of these public health authorities, and fundamentally trying to rebuild trust with the public, taking head on the misinformation and disinformation that has really been pervasive throughout this pandemic. And of course, that means addressing, quite frankly, with both public health officials and medical officials for whom they're not practicing what we've all know not to be the best science. And I think we've got to really address those individuals in a very frank and forthright way, because they're not doing any of us any good. They're hurtful to the public, and people will be not only injured, but they will die because of their poor clinical practice. And quite frankly, while we all value the First Amendment, and I also, of course, value that, bad clinical judgment and bad clinical advice, bad public health advice is terrible. So thank you very much.
Thank you, George. Next, we'll hear from Nashika Knight, Director, Workforce Transformation with the Association of American Medical Colleges.
Good afternoon. Thank you to the organizers for the opportunity to represent the Association of American Medical Colleges in this important conversation. As an ordained clergy person for more than 25 years, the mental, spiritual, and emotional thriving and flourishing of caregivers is a high priority. The AAMC is a nonprofit association dedicated to transforming health through medical education, healthcare, medical research, and community collaborations. Its members are all 155 accredited US and 17 accredited Canadian medical schools, approximately 400 teaching hospitals and health systems, including the Department of Veterans Affairs, medical centers, and more than 70 academic societies. Through these institutions and organizations, the AAMC leads and serves America's medical schools and teaching hospitals and the millions of individuals employed across academic medicine. Because of the breadth and depth of our member base, our solutions must be customizable in a variety of institutional types, sizes, and locations. And our well-being solutions reflect this diversity. And for the purpose of this meeting, I will focus on our student-focused efforts. At the AAMC, our approach to supporting student and trainee well-being is a balance of promoting personal storytelling and skill building, providing institutional resources and program evaluation, and addressing systemic needs such as destigmatization. On storytelling, skill building, and resource sharing, we developed the Medical Student Wellbeing webpage, which is an open access page for medical students addressing well-being and resilience in medical school. The page features short blog-style articles designed to inspire students to share resources for maintaining well-being and to highlight programs and practices that students, service providers, and medical schools have found to be effective in promoting and fostering wellness. The webpage has gained a lot of traction since it started, mostly because in addition to students sharing stories with one another, there are practicing physicians, faculty, and staff sharing their own challenges with medical education and how they overcame them to develop mental wellness and to find themselves in places where they can thrive. To address local learning and practice environments, AAMC administers a series of student surveys from pre-matriculation through graduation that assess students' personal and professional experiences along the medical education continuum. A recent survey of student wellness deans indicated that data from these student surveys are a primary source of information for determining what resources and curricula schools will implement. These surveys pay special attention to the following aspects of wellness: learning environment, learning climate, belonging, emotional intelligence and tolerance, adjustment to medical school, quality, accessibility, and usage of student services, and experiences of negative behaviors like mistreatment. In response to a need for effective practice sharing among student wellness deans and directors, and after a particularly moving conversation among student affairs deans whose schools have been impacted by student and/or resident suicide, the AAMC's Group on Student Affairs convened a working group on medical student well-being. Early in the COVID pandemic, this working group pivoted their work to develop recommended approaches for combating student isolation and mitigating mental health crises. I'll place the links to these resources in the chat a little later. In 2021, they resumed their previous scope of work. And most relevant to this meeting today is their consideration of systemic issues impacting the health and well-being of medical students. They determined, and we have learned, that it doesn't matter if we build resilience in future clinicians if they enter into systems that are toxic, that diminish their ability to thrive. So the working group ultimately identified 4 areas of focus within systemic issues. First, state licensure application information addressing mental health as a barrier to help seeking. Number 2, medical education program self-assessment tools. We've discovered that medical schools don't do a good job at evaluating the effectiveness of their programming and really assessing their culture and climate. Third, medical education program curricula schedule distribution. We found that learners not having their curriculums in enough time doesn't allow for them to plan their lives and coordinate their other responsibilities, and it's a cause for stress among late year medical students. And then finally, the 2 recommendations from the Coalition for Physician Accountability Undergraduate Medical Education to Graduate Medical Education Review Committee. 2 of those recommendations are focused specifically on wellness. This year, the working group is putting its energy into addressing the systemic issues that diminish mental health and wellness for future clinicians. For example, we at the association have begun to integrate wellness into the curriculum of our summer health professions education program for undergraduate students interested in health careers. Number 2, socializing the working group's national systemic recommendations. Number 3, creating a repository of wellness presentations used by allopathic medical schools that can be shared across schools. And finally, equipping medical schools with resources to support the mental health and wellness of minoritized and marginalized learners. So we appreciate the opportunity to share some of these efforts and resources with you, and I'm more than happy to put any of the links to these programs and resources in the chat. So thank you very much.
Thank you, Nishika. And our last speaker is Cha-Cha Chang, Coordinator for Total Worker Health Collaborations, Centers for Disease Control and Prevention, speaking for the National Institute for Occupational Safety and Health. Cha-Cha.
Hi, thank you. Thanks a lot to the National Academies for holding this important meeting. I'm pleased for this opportunity to share what NIOSH is doing. Besides examining N95 respirators, we want to support all aspects of worker well-being. We have a total work health program that has a vision that work can be a recognized means of achieving worker well-being. For healthcare workers, I think this goes back to that passion and spirit that inspired many to go into the healthcare field to begin with. We emphasize the institutional level challenges and opportunities for advancing worker well-being, such as hours and scheduling, return to work policies, psychosocial safety, and pay and leave. There are plenty of data on why worker well-being is important from an organizational perspective. We have a webpage on making the business case. Our Healthy Work Design and Wellbeing Cross-Sector Program includes economics research that also makes the case for a societal perspective. For example, impact on families, which has been mentioned today. There are decades of research that have identified risk factors related to jobs and duties, including organization of work, which includes factors such as flexibility and control, which other speakers here have talked about. We already know that job stress, which happens when the requirements of a job don't match the resources or the needs of the worker. When job stress is an overarching hazard, and that can lead to anxiety, depression, and burnout, which is a specific downstream outcome that's been of interest in this action collaborative. There's an international voluntary standard that was released last year. There are some countries that recognize the need to have occupational health psychologists on staff in their occupational safety and health teams. Based on established knowledge, we know it is important, as Dr. Murthy pointed out, to establish trust, take action, and deliver. Our suite of web pages and tools include promising practices that feature healthcare and other employers that have taken steps to improve worker well-being. Besides cross-cutting research and research translation, we also have a portfolio specifically focused on the healthcare sector. And as noted in the opening session, it's critical to have partnerships. We want to emphasize the importance of having actual healthcare workers at the table when making decisions. If there are unions, there should be union reps. If there are not unions, representatives of workers, so that it's not just a top-down, but workers are actually involved in decision-making, which, as everyone has pointed out, is a critical success factor for trust and transparency. I'll end with a couple of our newest initiatives. Last year, through the American Rescue Plan of 2021, NIOSH received funding to deliver a national awareness and education campaign. We issued a request for information to gain input from the public. In November, we had a webinar featuring Dr. Murthy, and it also included researchers, Lottie from the Action Collaborative, and a union. So it really illustrates the importance of having all types of workers, cross-sector perspective when you're working on something. And last year, we released the NIOSH Worker Wellbeing Questionnaire. It's a research-based new instrument that can be used to assess workplace policies and culture, worker perspective and experience, as well as the impacts of health, such as functionality. And one final thing is that in October, we will be having a total work health symposium. I'll end with a note of the importance, again, of having partnerships, workers and professional associations, such as the occupational health providers, occupational health doctors and nurses, their specific disciplines that are focused on occupational health, and even business schools or in public health schools, the health management programs, the ones who are going to be making the decisions in working with workers, as well as organizations such as human resource professionals, so that we are showing how many different partners all care about the same thing, which is worker well-being. Thank you.
Thank you, Cha-Cha. Well, it's been a whirlwind 30-minute tour of several national efforts, but we've heard about available for use resources and toolkits, as well as progress and plans that can be shared across the health professions, including efforts to diversify the workforce. From what we've heard, we recognize that unit level or frontline implementation is critical and requires investment from leaders to be successfully operationalized. We also note there's been unprecedented pressure on public health workers and disproportionate impact on well-being among women in the physician workforce, leading to their attrition from medicine during the pandemic. I want to thank all of the participants for your contribution to this convening. And now I will pass things over to Tina Shaw, Senior Advisor to the Surgeon General, who will be facilitating session 3, Commitments to Building and Sustaining Well-Being as a Core Value. Tina?